Welcome, everyone. Thanks so much for joining us today. My name is Jennifer Rubin, and I'm the Vice President of Partnerships and Special Projects for the American Society of the University of Haifa. We have all endured a lot over the last 9 months as COVID-19 has infiltrated and overtaken nearly every aspect of our lives. As many parts of the world are entering a second wave and seeing an exponential rise in cases, we have the opportunity to reflect and apply what we have learned through research, study, and practical knowledge in hopes we'll be able to mitigate future spread and impact through the course of the pandemic. In partnership with the Canadian Friends of Haifa University, we are extremely lucky to have assembled an esteemed panel of experts to offer the benefit of their knowledge and experience. Dr. MANFRED GREEN is the director of the International Masters in Public Health program at University of Haifa. He is the past head of the Public Health branch for the IDF and founding director of the Israel Center for Disease Control. Dr. DORIT NITZAN is the Regional Emergencies Director for the European region of the World Health Organization. She came to the WHO from the Israeli Ministry of Health and was also active in the humanitarian NGO Physicians for Human Rights. Dr. Andrew Morris is a professor of medicine at University of Toronto and the medical director of the Sinai Health System, University Health Network Antimicrobial Steward Program. Our panel today will be moderated by Dr. ROMANA PRIMUS. Dr. PRIMUS is a physician with over 50 years of experience in the medical field and was in private practice as a clinical immunologist and allergist. She is a Holocaust education activist and currently serves on the ASUH Board of Directors. Dr. Primus, before I turn things over to you, I'd like to remind the audience that you can submit questions through the Q&A icon at the bottom of your Zoom screen at any point, and we'll certainly do our best to address them all following the panelist discussion. Dr. Primus, everyone, over to you.
Okay, thank you. It's a pleasure to be here. Greetings to all our esteemed panelists and to everybody who's watching and listening. I'm sure we're all going to learn things today. So let's start with a broad question. We're approximately 9 months into the pandemic, and can we go around and each of you tell us, based on your areas of expertise, what's the most important thing we've learned about COVID-19, and what's the most important thing yet to be discovered? So why don't we start with Dr. Green?
Thank you very much, Dr. Primus, and thanks to everybody who's joining us. There's so many important things that we've learned, but I probably would give one negative thing and then maybe one positive thing. I think the negative thing is that we realized that we weren't prepared adequately for an event like this, even though we did have, I would say, many warnings that it could occur. So I think this is already a lesson for the future, and we can talk about it later on. The second point that you mentioned was, what was the second? I know
the most important thing yet to be discovered from your perspective.
Well, I guess everybody would say whether the vaccine is effective or not. There are so many other things. I think we're still learning also about the virus and how it behaves. But I would say, I guess we really need to know whether the vaccine is effective, or one of the vaccines.
Right. Dr. Thank you so much, Dr. Green. Dr. NITZAN?
Yes, thank you. I will try to look at it from Wgo perspective.
Yes, please.
And yes, we learned the importance of governance from one hand, and community engagement and trusted government from the other hand. So we see that countries, even though I agree with Professor Green that many countries are not prepared, those that manage themselves with good governance and really got the communities engaged, we see better kind of all of community approach. The other issue that we learned is that pandemic, I think some of us knew it, but definitely not in this magnitude. Pandemic does not only involves health. It has to do with life, with livelihood. and with all of government approach, also education sector. So I think this is something that we are learning how to deal with it. Thank you.
And the most important thing yet to be discovered, you think, is basically a continuation of that. Okay, thank you so much, Dr. NITZAN. Dr. Morris, you're muted.
Of course. Thank you, and thanks for having me here today. I think probably the one thing that we've learned so far is how absolutely complicated what on paper seems easy to operationalize is to be able to deliver in actuality. And whether it's something as seemingly simple or innocuous as getting people to wear masks, or effectively getting testing out to those who would most benefit from being tested. You know, the range of things that we thought seemed rather easy. There were concepts people had around imagining that we would be able to sort of, once we hammered it down, would be able to dance around the disease by just quickly identifying little flare-ups. You know, that inability to do that, the complexity of that was something that I think the world has recognized is a really large challenge that requires substantial local, regional, and international coordination. I think the one thing that we're yet to find out is whether or not COVID-19 is going to end up being something more like influenza, where it will be a recurring event with different degrees of severity over time, with perhaps not the most effective but still a beneficial vaccine, or whether after its few waves this will be somewhat palindromic and it will come, and then once it goes away it will be gone. You know, I think we are still waiting to see the results of that, and that's just going to be an issue of time. Right.
Well, thank you. So Dr. NITZAN, since the onset of the pandemic, how has the WHO responded, and how is it continuing to address the crisis at the moment?
Yes, thank you for asking this, because yeah, we have been criticized by some, and I think it's a good opportunity to actually show it from my humble perspective. So on the 31st of December, when our country office in China got this notice they did not even receive, they found in the news that notice on some kind of pneumonia. We did not even know about it until the moment that they verified it with the Chinese authorities and sent the message right away to all our offices in the world. And from that moment, literally, we started running, because we started to do something that I think with the preparedness, it helped us a lot. And this was the influenza preparedness work that has been done for years since the pandemic. What we did, we used all the channels, the networks of doctors, laboratories, and etc., to get the country's labs ready. Once we had, in the beginning of January, we already had the genetic composition of the virus. This became something that when we understood that it is moving from person to person, we could run quickly. So from that point on, we have been working in 9 pillars, helping the health system to respond during infection prevention control, strengthening the labs and providing lots of supplies to labs around the world because many countries could not do it. We also supply and provide expertise and experts, medical teams, our GORAN, the Global Response Network, as well as logistics support and advice, coordination, etc. I suggest that whoever has time and is interested, we have the timeline of our European region on the web, as well as the headquarters for the world. And there you can see with links what has been done day by day with the countries. And I think that, we have lots of criticism about ourselves. We would really like to be better, but most of it has to be with prophecy. And we try to do some modeling, and sometimes it didn't work, but we're trying to improve. I think we are doing better. Thank you.
Thank you. Dr. David Nabarro, who is the WHO's special envoy on COVID-19, he said in a recent interview, and I'm quoting, "We really do appeal to all world leaders. Stop using lockdown as your primary control method," unquote. So I'd like to hear from all three of you. To what extent do you agree or disagree with that? And to what extent do you think that lockdowns actually do cause more harm than good? And what other methodologies would you suggest other than masking that would be more effective? So why don't we go in the reverse order, and Dr. Morris?
Sure. So I think the premise of Dr. Navarro's statement is totally correct, and that is nobody wants a lockdown. I don't think that there's any serious person who's involved in COVID-19 who believes that lockdowns overall are a good strategy. And in my mind, they're not. Rather than them being a strategy, lockdowns are a recognition of failure of all other interventions to control COVID-19. Masks are a tool. I wouldn't think of masks as a strategy, and I don't want to confuse tools and strategies. There are two main strategies that are being followed around the world. One is trying to, in some ways, at a non-eliminated level, manage having patients or having people being infected with the disease, but preventing overwhelming spread and hopefully buying time. Whereas the other strategy is sort of the Taiwanese, Australia, New Zealand, and Vietnam examples, where you do as much as possible to essentially eliminate it or keep it at a very, very low suppressed level. I certainly err on that side primarily because of the failures we've seen with the other approach, and we're watching that in real time, not only what we saw in Israel, including right now, but throughout Europe right now, they're having that very same experience.
Dr. NITZAN? Thank you, Dr. Morris.
Yes, I think I could not hear. There's something happened. Can you repeat the question? Something was...
Sure, absolutely. So we're commenting on Dr. Nabarro's recent statement, which is that he would like world leaders to stop using lockdowns as a strategy, and whether you agree or disagree, and if you agree with him, then what other strategy would you think would be more effective?
Yes, and we do agree that the lockdown should be kept as last resort, so that countries will really try to adapt and go in a tiering kind of tier by tier, that we are building this on based on indicators that they would be able to avoid that phase where they really have no choice. And for that, we really, what we know now for sure, and that we learned, is that close contacts should be avoided. We all know that. We all know about tracing, isolating, quarantining, etc. But it sounds easy. We all know it. It's very hard, and we see the population fatigue in many countries, and the pandemic fatigue, we call it. And that actually one of the issues that we have to invest more. We have to invest with the people engagement, so that they will understand that without this, for a long time, definitely for a year, we will not be able to live just normal life unless you go with some of those who decide to let it go. And then it's lots of death, lots of people that are severely sick with a long COVID as well. So this is something that we really recommend to avoid, but not, sometimes it's not avoidable.
Thank you, Dr.
Over to you.
Dr. Green, you're muted at the moment.
Right, thanks very much. And I guess as Dr. Morris said, and Dr. NITZAN has said the same pretty much. None of us like the idea of the lockdown. It has problems, it has negative effects, it's not good. Unfortunately, the concept of the lockdown, and this is perhaps what the one sentence which I would have liked to hear from Dr. Nambaro, although maybe politically it might be problematic, is that we have a major issue with trust in government and trust in the people who are basically trying to manage the pandemic in various countries. And once you don't have that trust, you really lose many of the tools that you should have, because we recognize we have basic tools of social distancing, and there's lack of gatherings and using masks, which are pretty simple measures. But where there's a lack of trust, these measures are not implemented, and that's where we see the outbreak getting out of control. And that's basically where the reaction is really one where you try to make a decision between the expansion of the pandemic, the large number of lives lost unnecessarily because of this lack of cooperation from the public. And it's an issue that I think it's not just trust that you have at the time of the pandemic, it's trust that takes a long time to develop. And I think that that's another lesson that we need to learn, as to how to develop this trust. And I guess we need to educate our leaders as to how to operate in pandemics. One of the last comment I'll make, why there's a phenomenon which is very odd, and we're seeing it all over, that the people who were called in to handle the pandemic were almost never the public health people. The public health people were very much sidelined. These were the people who really should. And, I saw some of the data there that many of the committees and, that we used to handle the pandemic, maybe about 4 or 5% of the people on them had any public health experience, and certainly any experience in handling pandemics or epidemics. So I think that this is something we need to work on very hard, to make sure that the leadership recognizes that they have to develop trust with themselves and the public, and they have to have trust in their public health authorities. Otherwise, I guess we're not going to be able to succeed without lockdown. Yeah.
Thank you, Dr. Green. Dr. Green, we've seen reports from various vaccine producers about unexplained illnesses during trials. Recently, trials have resumed for 2 of them because they determined that it was actually not the vaccine. But how big a cause of concern is this? Does it change anything?
Well, I'm going to say something which is very familiar to the others on the panel and yourself as well. And I guess we're talking to a wider audience of people who are not familiar with how you test vaccines or develop vaccines. The protocol basically for testing a vaccine is and I've been involved a lot in testing vaccines, is basically a very strict protocol. And basically it says, if you have any suspicion of a possible association between the vaccine during the trial, you stop the trial and you try and determine whether there is an association. Almost always there's no association, but the recommendation, not just the recommendation, pretty much that's the protocol. So that shouldn't be a cause for concern in the sense that it's stopped. There's a concern if following the investigation, there is evidence that it's related to the vaccine. At the moment, I haven't heard anything, at least in the vaccines that are now being tested, where in fact the stopping was related to something that the vaccine was causing. So I don't think that certainly stopping the trial should not be a cause for concern. because that's an important part of the protocol. The next part will be, whether there was any association with the vaccine.
Right. I'm afraid, unfortunately, that some of the publicity associated with this has made some members of the general public a little wary because they're not accustomed to the protocols and they are just scared to begin with. So,
Right.
okay. Well, I think we've certainly learned a lot about therapeutics over the course of these 9 months. So I'm just going to rattle off a list of drugs, Dr. Morris, drugs or other treatments, and I'd appreciate it if you could just talk about how effective these treatments are and maybe comment on others, things like steroids, anti-inflammatories, convalescent serums, remdesivir, statins, antibody preparations, etc. If you want to talk about that, please, Dr. Morris.
Sure. It's a long list.
It is a long list.
We to take us back to February and March, we had 4 main candidates that, for a variety of reasons, people thought were going to be helpful. Those included hydroxychloroquine, tocilizumab, remdesivir, and corticosteroids. For a variety of other reasons, there have been other candidates that have come in and out of public discussion as well as scientific discussion. I think one of the most important things that we've recognized is that even without effective treatments, we've gotten better at treating COVID-19. So I think, I'm going to start off by saying that our overall approach, if you took a sick patient today and you compared that patient to a sick patient 6 months ago, they're far more likely to survive today than they were 6 months ago. And that's not a feature of the virus. That's a feature of experience and science and, just a better understanding. On top of that, we've also stopped doing bad things. And many of these bad things are things that we suspected might help, but don't help. And that could include hydroxychloroquine or zinc or azithromycin or a whole host of treatments that have largely failed. Probably the biggest, certainly the most robust success of everything has been a pretty simple drug, dexamethasone, or drugs like that. They are cortisone-like medications, and they reduce the mortality and severity of disease by about 1/3. That's pretty impressive. And it really has made a pretty substantial difference to patient outcomes. Remdesivir, or the brand name is Veklury, a Gilead product, is certainly a lot more controversial. If I were an American, which I'm not, I'm Canadian, but if I were an American, I'd be saying this is the best thing we have, certainly the best thing since sliced bread as it relates to COVID. But many other of my colleagues in the international community are substantially less certain of the overall benefit of remdesivir. It probably accelerates healing a little bit, but not nearly as much as some of the other treatments. Then I would say the other treatments that we're wondering about are convalescent plasma. And convalescent plasma is uncertain in terms of whether it's going to be beneficial. That's the plasma that's taken from people who have recovered from COVID-19 and then have antibodies. So we collect those antibodies to COVID-19 and transfuse them to people who are infected. Whether that makes a difference or not, I think we're still uncertain. Just today, released in the New England Journal of Medicine is a very preliminary results from Eli Lilly's monoclonal antibody trial. And I'm going to say the jury is still out with that as well. And all the monoclonal antibodies, we know that President Trump received 2 different monoclonal antibody cocktails, and it's uncertain whether that's beneficial as well. So I'd say in summary, there's a bunch of unknowns. Many things we know don't help and may harm. and dexamethasone is beneficial, and remdesivir is somewhat beneficial.
Okay. We've learned a lot about blood clots as a major factor in COVID. Do you have any thoughts about using anticoagulants, Dr. Morris?
You know, one of the things we've learned over the past number of decades is that people who are sick, especially people who are sick with pneumonias, and COVID-19 is a kind of pneumonia, are prone to blood clots, and other inflammatory processes also lead to blood clots. Whether or not at the end of the day, routinely giving people anticoagulants, blood thinners to prevent blood clots, and whether or not that is the right thing to do and improves the overall outcome for these patients remains uncertain. I think if I were to guess, I'm going to say they are a little bit beneficial, but I'm going to wait for the science to come out.
Okay, good. Science is good. Dr. NITZAN, you mentioned briefly about the disparity between how different countries are handling the virus. And I've been very impressed with some of the countries like Vietnam. And what do you think, which countries do you think have been doing an exceptionally good job handling the pandemic, and what can we learn from that?
It's so dynamic that if you would have asked me 2 months ago, I would have said Czech Republic, and look at us today. So I think it's very dynamic, and it's too early to actually say we will wait until this integral under the curve, to see the mortality, the morbidity, the long COVID, the other impacts on the community before we can really come and say, wow, these are the models. But in general, I think we see the two extremes that are kind of dealing with it okay. From one hand, and this is something that we really do not want to encourage, is of course very strong regimes that are, dictating the behaviors, etc. They do better. From the other hand, as I mentioned before, are those very solid democracies where people are trusting the government and are following, have been doing better. So in this group, I can, in the European region, I can say the Nordic countries in general, not all, but in general. Or you can go to other countries. But, for example, Italy. Italy was the first to get the hit, but they got their cells in the right way, manage it all right. And yes, we can expect that it will get worse. It is getting worse, but then they take the actions. So I think now Europe is kind of measuring the steps and making the approach in general. Some countries still are not yet marching in harmony with the people, but I believe that it will happen soon. Thank you.
Okay, thank you, Dr. NITZAN. So let's talk for a minute about herd immunity. The conventional thinking is that you need about 60% of the population to be infected to get to herd immunity, which means a low rate of secondary infection. So is there any way to calculate any way that you can think of, because I can't, when we will reach herd immunity? And do you think that this is a viable option? Do you think that a country could just say, okay, we're just going to go for herd immunity? Dr. Green, what do you think about that? We'll go around to everybody.
Thank you very much, Dr. Primus. I guess, again, I don't want to try and sound like I'm trying to teach people something they already know, but herd immunity essentially comes from the area of immunization. It doesn't come generally from naturally occurring diseases. And basically, we talk of herd immunity in terms of how we can immunize a population to achieve herd immunity. And that's what we've been doing for many of the vaccine-preventable diseases like measles, mumps, rubella, diphtheria, and so on, smallpox, if you like. So that, because these are diseases where you can vaccinate the population and reach a level of immunity that's adequate then to reduce the transmission to a minimum level. In the naturally acquired diseases, without a vaccine, I would challenge anyone to show me where herd immunity has really occurred without a vaccine. It's a very difficult question to ask. I mean, just about every disease we know prior to the introduction of vaccines has just not disappeared just by naturally acquiring. I mean, many of them you can talk about. We can talk about measles, periodic outbreaks or epidemics of measles, which went on every year or every 2 years until a vaccine was achieved. We never achieved herd immunity.
Right.
But that's a problematic disease. So let me just add a point. I think here there is another issue, and that's related very much to what I said. And I'll use the measles as an example. In measles, for example, the public was exposed to measles for many years, hundreds of years probably. And they developed immunity as a result of natural infection. So you always had virtually the whole population immune except for the new cohorts of children that were coming in. And they got measles and then the next cohort came. So you had, if you can think of it, as a structure of the population where the very young were exposed. In other words, they were not immune, and the older part of the population were already immune. In COVID-19, just like any new infectious disease, it's the other way around in a sense. Because if you think about it, the concept of now achieving health immunity by exposing the younger people means that you leave the older people exposed. So you don't actually achieve the situation where, in fact, you've got an older population who's immune, and the new cohorts or whatever, the young people will then get infected, but the older people don't get infected by it. Just in measles, we don't see much measles. Even in the measles epidemics, you very rarely see much in the older population. So what happens in this situation, I would say herd immunity in that situation for COVID-19 could probably be achieved over 20 or 30 years, because we'd have to basically expose the whole population and achieve this adult population that is immune, and the new cohorts of kids coming in would be non-immune, and then so on and so forth. And then they would be the ones who couldn't infect the older people, and some of them would get infected. So I think the bottom line is, my answer would be, we cannot achieve herd immunity used by natural infection, except, of course, at a huge price, if we decide just to let the pandemic expand uncontrolled, and then say, okay, we've managed then to expose the older population who cannot really be protected. I mean, that's, I think, an illusion. And then assume then that we can then deal with the younger population who will be less affected. So essentially, I'm saying that this 50 or 60%, I think that's based on a formula for vaccine preventable diseases. I don't actually believe it applies in this kind of situation. I'm not saying that the number is wrong, but you need to have a vaccine to apply it. When we have a vaccine, then we can talk about 60% or whatever that we need to vaccinate in order to create herd immunity.
Thank you, Dr. Green. Okay. Dr. NITZAN, Dr. Morris, does either of you have something to add?
Yeah, maybe. Thank you. Thank you, Dr. Primus. I just want to add, because I totally agree with Manfred. I think that another aspect is the fact that the animal kingdom is also hosting the virus. And we see it in minks, also cats, dogs, other animals, and bats, of course, and I don't know. I think once it's not only in the human kingdom, and therefore it would be extremely hard, because let's talk about the smallpox, or, that was eradicated. Of course, not herd immunity, but it was eradicated. But this was because it was purely human disease. Here, I think that we are going to be challenged with, such attempts. And I suggest that we just keep our distance and learn to live until we get the immunity with the vaccine. Thank you.
Did you want to add anything, Dr. Morris? If not, we'll move on.
I think you can move on. It's okay.
Okay, so let's talk about vaccine, since that's where the previous question has led us. And we all know that it usually takes many years to develop a vaccine, and we all know that there are many manufacturers racing to meet this need. So when do you think that there'll be realistically a safe and effective vaccine? Let's just talk about the country like Israel, US, Canada. So Dr. Morris, do you want to start?
Well, I think it's anyone's guess when we're going to have a safe and effective vaccine, to be honest with you. Coronaviruses are rather difficult to develop effective vaccines. It's not like the world has been sleeping on influenza vaccines, and having an effective vaccine for influenza that has eradicated influenza hasn't occurred yet, and we've been trying this for decades. So I don't know. Obviously, there's a lot more money, effort, resources being placed into a COVID-19 vaccine. So I do have some hope from that perspective, but I do think we have to temper that hope with some realism that just having a safe and effective vaccine and being able to confidently be able to deliver that out it's entirely uncertain. And so I think it's anyone's guess, to be honest with you.
Okay, I think we're probably all agreed on that. Does anybody want to add anything to that? Okay, so Dr. NITZAN, currently there is no process for sanctioning a country that doesn't abide by international health regulations. Do you think there should be? And if so, what do you think those sanctions might look like?
Yeah, I think that there are some issues with the IHR 205 that probably needs to be fine-tuned in order to make them effective, because, we can do with the IHR whatever is dictated by the IHR. We cannot come and do things that we're not there. So we have now the IHR Review Committee gathering.
I'm sorry to interrupt you, but just for people who don't know, the IHR is the International Health Regulations.
Yes, International Health Regulations, and the last one is from 2005. And these were like really good regulations that opened us for many hazards, including, of course, outbreaks, but in general, not telling us only to limit our work in regards to specific ones. Still, I think after this pandemic, or during this pandemic already now, we are learning about some fine-tuning that should be done in the IHR, in the International Health Regulations. And for that, I think one of them would be the sanctions, but also the other one is the way that we are allowed or entitled to get information from countries that decide not to share, or they don't know how to do it, etc. So I think these are the issues that need to be fine-tuned.
So the sharing of information is critical, isn't it? Right. So there's a question from the viewership that is a little bit relevant here. Somebody in the audience asked Dr. Green about whether there's a need to involve whether there are any examples of successful engagement of public health stakeholders during the pandemic in Israel, and the potential, or anywhere, and the potential of applying these to Israel.
Yeah, I'm almost tempted just to start talking about the failures, because there have been some very notable failures. And I guess this is something that needs to worry us. So I'll actually just start with a couple of statements on that and then go over to it. I think that, as I said before, the public health leadership, or the public health community, the professionals in many of the organizations, if not most, are very good, well-qualified people. They've been trained to do what they're doing. And if you look at the international WHO leading it, and the governments have, and the US has the CDC, which has always been very much admired, and the UK having the National or basically, I suppose, public health, England and so on, and Canada and so on. So these are countries that have very strong people and public health services, and in Israel to a large extent. So you need to ask the question, why is it that the governments, both the governments of the countries and maybe others, fail to, as in my opinion, fail to trust them adequately or give them the lead in leading the struggle or the fight or whatever you want to call it, or the control of this pandemic, and started to sideline them in many cases. And I think this was a reaction which was very unfortunate. And this what created, I think, a lack of trust also in the leadership of the countries, not just. So what was happening then is both the governments of the countries lost trust, and they caused a loss of trust in the public health agencies, so that the public health agencies became almost the enemy of the people, where they were introducing regulations which were very uncomfortable, and the governments were unable basically to give them the lead, basically professionally, to show that basically they are doing the right thing and give them back basically the lead. So I would say that there do seem to be countries, I guess in Denmark, this is an example which I'm familiar with, and DORIT knows it very well, where it does seem there that both the leadership, the government, is very trusted, and also they have the very good public health community, and so this combination was very successful in gaining the trust of the public in actually, collaborating or cooperating with the measures that were taken. And there's I feel at least, much less hostility, so to speak, against the public health people. But I think that we need to look over the world. I mean, if you look at what happened, this is a very worrying sign that large countries like the US and not Canada, I don't know, but the UK and a couple of others that I noted were basically, and Israel as well to some extent, were changing or trying to sideline and maybe put new people into place because they didn't trust the people they had, which means that they didn't actually have a public health service in place that they trusted, and that's a very dangerous situation, and that has to be changed. So I think that this is of course, I mustn't forget to mention Dr. Fauci. Dr. Fauci, of course, is a symbol now of someone who is a great professional and very trusted. So we need more Dr. Faucis, and we need governments that trust people like Dr. Fauci.
So, yeah, I think that there's a distrust between the population and the government, and a distrust between the government and the public health organizations, and then a distrust from the population to we've got a triangle of potential distrust, and that's certainly not something that you can rebuild overnight. But does anybody else, Dr. Morris and Dr. NITZAN, would either of you like to comment on this?
Yeah, I think, if I may, we've learned a lot, and one of the challenges that we should have appreciated, but we definitely underappreciated, is I think the marginalized populations. And what is a marginalized population varies from country to country, from region to region. But the importance of marginalized populations as part of as an important element in an ecosystem of infection transmission is really very important and probably understated. And that ties very closely with what Dr. Green was referring to, because there are actually three players in all of this. Of course, there's public health, there's government, and there's the public. And depending on where you sit in the socioeconomic spectrum really determines how you feel about the different measures that are implemented by government and public health, or at least proposed by government and public health. And yet those most important elements that I've mentioned are the least politically active and savvy. And so they end up being the earliest forgotten, and it results in us probably performing our task at hand less well than we would have otherwise.
So are you saying that if more attention is paid to the marginalized populations, that we would do better in the future.
Absolutely. There's no question in my mind. And when I say marginalized, you know, it doesn't have to be socioeconomically marginalized. It can be ideologically marginalized.
Right. No, I understand.
So, right. So we saw that in Israel for sure with the Orthodox population, who I'm going to say from an ideologic point of view were marginalized, and attending to them is equally as important as here in Canada attending to the socioeconomically marginalized.
Thank you, Dr. Morris. Dr. NITZAN, did you want to add anything?
I can just say that, yeah, I totally agree with both. And the other aspects that I wanted to bring is the importance of public health. And I think now the world is aware of epidemiologists and contact tracing, you know, all these terms that many people did not hear and know before. So we kind of we need to strengthen the public health, but we need to come to the grassroots level, and we need to speak with the people, for the people. I totally agree with the fact that we have to listen and get all of the people, including those that are left behind or marginalized, to have their voices, and into the public health, also not only primary care and hospital, but also the public health that, usually it's more in the governance. It has to go to the field. Thank you.
Okay, so we've already touched on this a little bit, but let's just take this a little bit further, since I think most scientists agree that this is not our last pandemic, that we're going to have more pandemics in the future. So what do you think we've learned from this latest crisis that can be implemented for the next one that comes along, or investigated so that we can deal with it better? So I think we'll let Dr. Green start, and we'll go around.
Thanks, Dr. Primus. I think it's a continuation, basically, of our previous discussion. I think I've been involved to a fair amount in bioterrorism and preparedness for bioterrorism. And it's not very different from preparedness for pandemics. It has very much the same kind of concept. And one of the problems with preparedness for bioterrorism is the skepticism that there ever will be bioterrorism. So the skepticism results in a lack of resources and a lack of training and a lack of preparedness. And the same thing goes for pandemics, but we don't have one, it could be a pandemic, it could be a large outbreak. We have that all the time. We have near pandemics, which people I don't think will realize. I mean, we're having near pandemics all the time. Easy to talk about the ones that happen, but it's not easy to talk about the ones that nearly happen. So what I'm saying is that I would suggest if we came out from this group here with a statement or a project, I would say that we now, and this may of course be doing that what needs to be done urgently is to, and I would suggest WHO takes the lead, but you can work out a way in which it's done, in strengthening public health substantially and strengthening the trust between government and public health and between the public and public health, improving the status of public health professionals and making sure that the resources that go to public health are basically the resources that are needed, not just for day-to-day, but also for preparedness for emergencies such as this one. And that requires an ongoing basis. I'll maybe make one comment about the US that I'm familiar with. Fort Detrick, which is a center of the US Army, was based, or still, I guess, but worked very much in the field of developing new vaccines and diagnostics and so on. They had an amazing setup there that I happen to be fortunate to have worked with them. And that was set up basically for the military, but it had a huge amount of civilian applications. I'd heard that facility, in the terms of it, was gradually being phased out or shut down because it was felt that it wasn't worth being funded. These are exactly the organizations that we need. It doesn't have to be only in the military, but CDC, WHO, Canada's public health, whichever, all of them have to now be given priority. And they have to have the resources both for people and develop this trust then, that the public and the government trust these organizations as the advisory bodies that they believe in. And I think that'll make a big difference.
Yeah, so in the United States, a lot of the public health measures and money for public health organizations has been recently decreased in the last few years. So obviously we've learned that was a bad idea. So Dr. NITZAN, what would you like to add?
Yes, I think that what we see is very interesting. We think that we are in the 21st century with the high tech and everything. And you know what? We woke up to a world where basic public health was called to order. And that is something that is very challenging, because we could see that even the most developed countries, and this pandemic is different because it started or moved very quickly to the European region, where they have very, good health systems, some of the countries, universal health coverage, IT, and many others. So we learned that the basic things have to be, people have to be trained with the basic issues, also public health, but also others, as well as putting money into the R&D, to the research and development. Research and development, each country should really invest into it. And I remember that I was so impressed when I was a kid here in Israel, and we learned that the Weizmann Institute was established, really side by side with the developing these pioneers and the pioneering country. And that was something that, with a vision, forward vision. And I think that this has to be one of the things. While we keep it basic, simple, and in place, we have to have very strong research and development, and very strong also behavioral sciences that are linked with each other. So for me, the fourth point is actually understand that we have an enemy that is fighting humanity. The virus doesn't want to fight us, but they found heaven among us, so they want to stay with us. And here, nationalism and keeping the borders closed and keeping the research, the vaccines to only one nation, that won't be good. So I think these are the things that I take with me. Thank you.
Thank you, Dr. NITZAN. Dr. Morris.
I'd make just a few points. One is we ignore infectious disease threats at our own peril. And whether they are rapidly spreading viral infectious diseases or antimicrobial resistant organisms, we ignore these at our own peril. And so we have to pay attention to that. The second thing I'd point out, and Dr. NITZAN looked at it, in Canada, we've gone to the Australian model in the Olympics of shooting for gold by focusing on your elite. That's one way of pursuing sports, is by you focus on the highest level, like your universities and research institutions. But I would argue that what this has really exposed is our need to focus on children and their education of science and the social sciences as well. And I think that if we had a public that were scientifically literate in a much higher degree than they are, we would have largely different outcomes than what we've observed. It would be an effective foil to pseudoscience, denialism, and misinformation. And so I think if there were one thing that I would absolutely focus on, would be having all kids really understanding a lot of the science of what's emerged from this. There's been fantastic knowledge translation and education to the public through the media, but we could do so much better with young minds, and many of them hopefully would end up being those researchers and developers that Dr. NITZAN was talking about.
Thank you. I think that point about education is really very important. Okay, so eventually there will be a vaccine, we hope. And what considerations do you advise for the average citizen to use in deciding whether or not to get a vaccine, and whether to be, on the front line of getting a vaccine or to wait cautiously? How do you think the average person should view that? Dr. Green?
Thanks, Dr. Primus. I'll start off being provocative because I have a slightly different view, and I know that maybe I'm in the minority, but I'll hear from the others. I actually think that the first people to be vaccinated should be children, and I'll explain why. I think that children should go back to school, first of all, and I think we should protect them, first of all, from disease when they go back to school. I think that they are the ones also, with all the limitations of the spread of COVID-19, I still think that they are a source of infection to older people. So once they're vaccinated, they can go and visit their grandparents and they can hug them, and they're not going to be as much of a danger, if at all. And the third thing is that children respond very well to vaccines. Unfortunately, people like me, who are a little older, don't respond that well to vaccines. So if the vaccine, like the influenza vaccine, is not that effective, in people like me, it'll be even less effective. So I would say that my approach, and again, I agree that I know that from a kind of public health point of view, or not public health, public opinion point of view, it's not easily accepted. But I think that intuitively would say vaccinate the ones who are at highest risk, the elderly and the ones who have chronic diseases and so on. I would start with children and healthcare workers and then go to the others. So let's hear some other views.
So I think that's really interesting. Thank you, Dr. Green. Dr. NITZAN.
Yeah, I think that I would be more ordinary and saying that my priority will be the healthcare workforce first and the life-saving. So I would go for the vulnerable, the at-risk populations, and then go to children. But I can understand the Manfred's logic. It's hard for me though, because I think I would like to save lives first as much as possible.
So what and how do you think the ordinary citizen should decide whether to get a vaccine? What should the criteria be?
I think that once the criteria agreed by the country, first of all, I think we will, WHO is coming with our own recommendations, but then the countries will have their own decisions. I think that I would expect that the people will comply, because once we have that, we should not deny it. I would not wait longer. And I know that some people are fighting vaccines. They think that they are not safe, etc. I think that it's our obligation to get vaccinated if and when we will have a vaccine. This I'm not sure.
Dr. Morris?
I guess I'll start off by saying that if the international scientific consensus is that we have a safe and effective vaccine, then anyone who can get one should get one. But in terms of prioritizing, I believe it's the intersection of how essential somebody is in being in a congregate setting and how vulnerable they are in that congregate setting. And it will need to be into that interface. So I share Dr. Green's desire and concerns to get kids back in school. I will consider children in school as essential. It's only slightly less essential, though, than people who are in long-term care facilities, for example, or people who are in hospitals, where they, by and large, don't have a choice, and we don't have a choice or another option other than them being there. And so that's why I would probably prioritize that congregate setting just a little bit higher than children in schools. But to me, that's how you work your way out, is the interface of vulnerability and how essential people are in certain congregate settings, and you move outward from there. So people who interface with very few other people probably should be lower on the totem pole, so to speak, because I just don't think they're as a higher priority here.
Well, thank you. I want to thank everybody, Dr. Green, Dr. NITZAN, Dr. Morris. I think this has been a really good discussion. And I just want to point out two things that I think have not been a part of the general public discussion that were brought up here. Well, three things actually that were brought up here today that I just want to point out. One is Dr. Morris's point about educating kids in the sciences. I don't think we've talked about that in the public in relation to this pandemic, and I think it's really vital. The second one is Dr. NITZAN's mentioned just briefly about involving behavioral specialists in the public discourse and in training people in terms of the importance of public health. And I think we've neglected that as well, and it has been largely the uneducated public response that has been a real stumbling block, and maybe behavioral specialists would help us with that. And the third is Dr. Green's intriguing concept of vaccinating children and making them, children in school, an essential population type. So I want to thank you all for these really intriguing ideas and tell you all to stay safe.
Thank you very much, Dr. Primus, on behalf of all of us. I guess we very much enjoyed your moderation.
Yes, thanks so much.
And thanks to Dr. Morris and Dr. NITZAN for being so kind to be with me.
You.
Likewise.
I hate that we're out of time. I just very quickly want to say thank you, Dr. Green, Dr. NITZAN, Dr. Morris, Dr. Primus, for sharing the benefit of your invaluable experience and for the work you so tirelessly are committed to in the service of public health and safety. I also want to very quickly thank and recognize Dr. Arnie Aberman, President of Canadian Friends, for his partnership and support, and also my colleague, Hetty Shapiro. If you have any questions or would like more information about today's presentation or anything related to University of Haifa, please contact us at info@asuh.org. If you would like to support any of the university's COVID-19 related research efforts, the University School of Public Health, or any other university faculties or programs, please visit www.asuh.org/donate. Thank you everyone for joining us today. Thank you for our wonderful moderator and panel. To everyone, please be healthy and well, and we'll look forward to seeing you soon.